start at exactly 6. Please take your seats. Okay, please take your seats. Hello? Hello? I am looking for total silence, so please take your seats. Please take your seats. I know it's great to meet. I know that we have 7,000 people around Geneva this time. And I know that we missed each other because of isolation post-COVID. So please take your seats and we'll have a lot of time for you to get to talk to each other after. So, all right. My name is Dr. Githinji Gitahi, and I would like to ask for your silence, please. I still hear some sounds around here. Ted, yeah, thank you. I'm watching you. So, okay, good. Good evening again. Good evening. Thank you. My name is Dr. Githinji Gitahi. I am part of PMNCH. I co-chair the Advocacy and Partner Engagement Committee. And when I'm not doing that, my side hustle is that I'm the group CEO for AMREF. That's really my side hustle. And as we are all settled, let me get my, thank you. I love that silence. And that's the silence I want, because I want us to do something that you probably haven't done before. So no movement, silence for exactly 2 minutes. I'm sure you've never done that before, but starting now, silence for exactly 2 minutes. You'll be uncomfortable, but I'm timing. So until I say stop, silence for 2 minutes, starting now. Thank you. one woman has died of preventable maternal or childbirth-related death in those 2 minutes. 2 adolescents have died in those 2 minutes, those very uncomfortable minutes. And 20 children under 5 have died in those uncomfortable 2 minutes. I know how uncomfortable that was, but the causes of their death are preventable. Science is there. So they have died in those 2 minutes because of inaction. Our inaction and the inaction of those who are not in this room. Now multiply that 2 minutes of uncomfortable silence, of inaction. Keep multiplying that and see how many people will continue to die of that inaction. Whereas we celebrate great gains that have happened, we have child mortality has dropped significantly. The statistics are known, I don't have to recite them. We have reduced maternal mortality. We have reduced neonatal mortality. We can't celebrate because progress has stagnated and in many places regressed. So we have to think about that. We have to think about those uncomfortable 2 minutes and the costs of our inaction. That's really what we need to think about. This is a global issue. Whereas those numbers are worse in low-income countries, this is a global issue. This is a human rights issue. And we are seeing gains being lost. But we have made promises every year. We've come here. I was reminded that PMNCH action has almost consistently held a Sunday evening get-together to discuss these matters. PMNCH is going to be 20 years old, and that was a global commitment of PMNCH. We have SDGs coming up 2030. We've been told that they're awfully behind. Lives are in the balance, and it's up to us to then say, what do we do to move forward? I want to ask for a video that's going to reflect on keeping the promise. So give us the video, Keeping the Promise. Ladies and gentlemen, welcome to Protect the Promise. You can clap for the video. Thank you. Political action is needed. We need to galvanize political will. Health is a political choice. Human rights are a political choice. And today, we are glad and honored to have Dr. Sandile Buthelez, who is going to present to us a message from the leader of the Global Leaders Network, President Cyril Ramaphosa. So I'd like to invite Dr. Sandile Buthelez to give the keynote on behalf of the President. Welcome, Dr. Buthelez.
Thank you, Program Director, Honorable Ministers, Excellencies, members of the board of the PMNCH, colleagues, friends. Thank you. At least you put it clear so that I can make a disclaimer. People might think that because there are elections in South Africa in 2 days' time, probably I'm standing here. But I must say I'm representing President been asked to read the message on behalf of President Cyril Ramaphosa. My name is Sandile Buthelez. I'm the Director General of the Department of Health in South Africa. And I won't paraphrase the letter, so I will read it as is. Starting, dear friends, last year on the margins of the 78th United Nations General Assembly, we launched the Global Leaders Network for Women, Children, and Adolescents Health, with the support of the Partnership for Maternal, Newborn, and Child Health. This initiative was born out of a conversation I had with the board chair of the PMNCH, Honorable Helen Clark, former Prime Minister of New Zealand. We agreed that there is a need for bold leadership at the highest political level to address the challenges in progress, towards the sustainable development goals, which is SDGs for women, children, and adolescent health. I take this opportunity to thank His Excellency, Mette Frederiksen, Prime Minister of Denmark, and His Excellency Sheikh Hasina, Prime Minister of Bangladesh, for joining me in this network. I look forward to many other peers joining this initiative. I am pleased to convey this message of support as you contemplate a proposed resolution on maternal, newborn, and child health on the margins of the 77th World Health Assembly. This event is a necessary and timely meeting to reaffirm our commitments and take substantive steps to ensure that no woman dies giving birth and that newborns and adolescents not only survive, but thrive to reach their full potential. One of the reasons we elevated this issue to the heads of state level is our recognition of the need for a multisectoral response to the challenges of morbidity and mortality for women, children, and adolescents. We know that successful approaches include 1, high-quality essential health and nutrition services, 2, investing in the training and retention of skilled health workforce, 3, stronger primary healthcare delivery, 4, prioritizing issues of access, which include navigable roads and transport to reach all communities and for all community members to be able to reach facilities. Number 5, universal access to reproductive and sexual health services. Number 6, access to sexual and reproductive health commodities, including through localized manufacturing and more investments in climate resilient and sustainable health system. Investing in women, newborns, children, and adolescents is a moral, a social, and an economic imperative. Investing $5 per person per year in health systems and high impact health interventions for women and children health in 74 high burden countries can yield economic and social benefits that are 9 times greater than the amount by 2035. Similarly, every dollar invested in selected adolescent health interventions yields a 10-fold return in health, social, and economic benefits. I strongly encourage the inclusion of leaders in the sectors of finance, public works and infrastructure, manufacturing, gender equality, adolescent health, business, and civil society. In this conversation, I encourage them to join in these conversations. The final push towards the 2030 Sustainable Development Goals will need all of the society's best efforts, guided by evidence and a robust forecasting framework. As part of the Global Leaders Network support, we have identified 11 of the most affected countries in the world to support an accelerated program of action towards SDG targets of maternal and neonatal mortality. These are Ethiopia, Nigeria, Sierra Leone, Malawi, Zambia, Tanzania, Senegal, South Africa, Kenya, Bangladesh, and Liberia. These countries also have a high burden of adolescent mortality driven by a myriad of socioeconomic issues. Although adolescent mortality is not an SDG target as such, we have decided to give this indicator the same energy and political attention that the other SDG targets enjoy. I am pleased that the resolution places emphasis on adolescent health and well-being. I encourage further development in this area and will be glad for us to work towards giving adolescent health and well-being the political prominence it needs to successfully reduce preventable deaths and morbidity among young people. I wish you all fruitful deliberations. Please be assured of our support and commitment towards health security for all, especially women, children, and adolescents, which is essential if we are to attain our aspiration of a better world. Know yours sincerely, Mr. Cyril Ramaphosa, President of the Republic of South Africa. Thank you.
That is fantastic. And we wish to thank the Prime Minister of Bangladesh and the Prime Minister of Denmark for joining the Global Leaders Network. Good to see you, Helga. Thank you. All right, good. Now the stage has been set. There is political commitment, and we thank Professor Ramaphosa for pushing forward and getting us where we are now, because without political commitment, we will not achieve the promise that we have made. But we would like now to go to understanding this promise and what it means when we don't achieve it and what's going on the ground. So we are going to have a session with ministers of health or their representatives to actually paint the picture, what is actually going on the ground. So I'm going to ask the following to come up. First is the Minister of Health and Family Welfare, Bangladesh, Dr. Samanta Lal Sen. Please, on my left, sir. Thank you. The Minister or her representative, the Minister of Health, Population, Health and Population in Malawi. I'm told that Lucy Mkutumula, who is the Deputy Director of Nursing and Midwifery in Malawi. Welcome. Welcome, Lucy. You're the Minister of Health for Malawi today, so welcome. The minister is my friend, so I'll let her know that I did this on her behalf. Next, I would like to invite the Minister of Health and Sanitation from Sierra Leone, Brother Dr. Austin Demby. Austin, please come up. I have a cheeky addition in between here before the other panelists, and I would like to invite my sister Joy Phumaphi to come up on stage. Joy has a long history, former Minister of Health in Botswana, and currently the Executive Secretary for ALMA, and also co-chairs the Advocacy and Partnership Engagement Committee at PMNCH with me. Thank you, Joy, for coming in. And finally, and not least, I would like to invite Dr. Guled Ali. He is the Director General of the Federal Ministry of Health in Somalia. Please take the last seat. And this WHA 77, we have a resolution that was proposed to the WHA 77 by Somalia. You would imagine that Somalia has actually seen the impact at community level, at household level, of this failure in delivering the promise. So Somalia represents all those countries that are actually most left behind on this promise. And we must thank your government, Dr. Guled, for actually taking a step forward, mobilizing other countries that have supported you to take this resolution to WHA 77. And the resolution is already in draft. So I would like to start with you to actually present the case behind this resolution, what is aimed to be achieved on this resolution, why, and if you could do that in 3 or 4 minutes, then we'll ask our panelists to respond and to comment on the resolution itself. So over to you, Dr. Guled.
Thank you, Program Director. First, I want to thank the organizers of this event and those who committed to attend. in this high level policy area. As you highlighted in your opening session, every minute costs the life of a child or adolescent in the world. So inaction or silence means complicit to let that child or adolescent die. So Somalia is part of the countries who have faced similar challenges when it comes the stagnation of or lack of process of reducing maternal and child mortality rates. We face these challenges. Some African and Mediterranean and Asian countries have faced similar challenges. So when you look at the data or statistics, it shows negative to the countries, or it shows a huge challenge on their healthcare. So for us, concerned by that stagnation on maternal and child mortality rates and lack of the progress, we have proposed to this resolution on before the executive board of the WHO, Somalia, WHO. The aim we put forward on this resolution was to accelerate actions or reduction efforts of maternal and child mortality rates on the similar countries we face the same challenge. We were championing of to bring the attention of the inaction that the currently are facing these countries, or the stagnation of reduction of the maternal and child mortality rates. This proposed resolution is sponsored by even countries who have no similar challenges, like Canada and Denmark, but they feel that the importance of solidarity of the countries who have facing these challenges. So as a Somalia, since we are the most, I can say, the most 5 low maternal and child mortality rate in the world, in the globe. When you look at our data, it shows we are quite far off track on achieving the SGDs in 2030. When you look at the current trend of our maternal mortality rate, it quite shows 621 against 10,000 of lives of mothers in our country. So in 6 years of time, we need to accelerate the reduction of almost 10 times to achieve the desired outcome, the SDGs. The same goes the child mortality rates. So we faced a similar challenge. The number of countries in Africa, a number of countries in the Mediterranean and the Asia. So we put this proposal to bring the attention also and to accelerate the actions required to reduce the maternal. And the importance at global level, it's clear. We aim to achieve off-track countries to speed up the progress. And because when you look at this period we have to achieve the SDGs 3.2 and 3.1, the 6 years of time, you can see there is a number of countries who are off track. For example, 59 countries are off track for under 5 mortality rates. 64 countries are off track for newborn mortality rates. So that kind of off-target countries who are not beating the numbers to reduce need to accelerate. So we are here since facing this challenge, we are here to bring the attention of our global partners and countries who are facing the same challenge to accelerate their action and galvanize efforts regarding reduction of maternal and child mortality. The other aim we want also to achieve on this issue is when you look at the disparities on the healthcare across the globe, it clearly shows that there is inequality, inequitable distribution of healthcare resources on investing of the healthcare across the globe. So to address such a challenge, it needs to bring the attention also. These kind of disparities will not be helpful if we want to reduce mother and child mortality rates on the challenge on the countries like Somalia who face these challenges. Also, what we want also to bring attention is these leading causes of mortality rates of the mothers and child. It's preventable, but it needs just action.
Correct.
Yeah.
Yeah.
It's not something unattainable. It's something can be prevented. If we improve our immunization programs, if we improve our access to the basic healthcare, if we improve our quality healthcare, if we improve of access to essential medicines, all these, it's preventable.
Yeah.
So if we did all these efforts, we can prevent the tragedies that our mothers and child are facing in countries like Somalia.
Thank
those
you.
who share the similar challenge.
Yeah, thank you very much. And we have actually a very successful case of exactly what you're saying, that these things are preventable. It's actually in action. And here we have the Minister of Health from Bangladesh. And if I was to just reflect on what you're talking about, Somalia's maternal mortality rate is, you said it's 621, 624 per 100,000. Who can guess what it is for Switzerland? Switzerland, 100,000 live births. Yeah, 3.4 per 100,000. So 3 is 5 there out of 100,000. That is, you can divide 624 by 5, and you can see the risk of being a woman in Somalia. This is what we are talking about. Yeah. And under 5 mortality.
100.
It's 100.
105.
105
yeah.
in 1,000. In here in Switzerland, I think it's 3 out of 1,000.
Yeah, we are part of the 5 countries across the globe who are exceeded 100 deaths.
Absolutely. So being born in Somalia is already a risk. Just being born there. And this is what we are saying. We have the science. We just need to take action. So before you continue, Dr. Guled, I would like to ask the minister from Bangladesh. I looked at the data for Bangladesh, and I have seen, for example, that you brought down maternal mortality from about 434 in 2000 to 173 in 2021. Is that true? And the same for under 5, you brought it from 42 deaths per 1,000 to 17 deaths per 1,000. So what Dr. Guled is saying is possible. So maybe you could reflect on what Dr. Guled is saying. So what has Bangladesh done that we can actually take and say, this is the pathway to action? Over to you, Honorable Minister.
Thank you. Thank you, moderator. Thank you very much. The distinguished, my colleague, the ministers, and the distinguished guests. At the very beginning, I'd like to thank the PMNCH for inviting me to this panel discussion. You know that Bangladesh, under the leadership of our Honorable Prime Minister Sheikh Hasina, we have eliminated Kalajor completely. It's the only one country in the world. Mm-hmm. So we are also now trying to reduce the maternal mortality. And we think that we can reduce the maternal mortality. How? This is, we know we have got a lot of Upajala Health Complex Community Medical Center, where our people, we ask the ladies to go for the antenatal checkup, which is very important. If we can ensure and confirm the antenatal checkup, and if we can ask our ladies for going to the institutional delivery, which is very important, because in our country, when I was born, I didn't go, my mother didn't go to the hospital. So I was born in a village, in a village home. But now we have got all the health complexes, community clinic. So if we can insist our women to go to the institution like hospital, so that we can reduce the maternal mortality. Also, you can see this for this child mortality, our EPI vaccination program is very important. We are giving this EPI vaccination against 10 major diseases, including hepatitis B. Also, recently, the HPV vaccination program to prevent the cervical cancer. We are launching a VaxP, which is a based online registration. So we working at the grassroots level to reduce the maternal mortality. And our Honorable Prime Minister is very, very much committed to reduce the maternal mortality, and we all work together to reduce our mortality. Thank you.
Thank you very much for that. I think you are saying it's possible.
Yeah,
it's possible.
It's possible.
And you have managed to gather the political support at the top. But
and I think the awareness is very important.
Yes.
We have to teach our ladies to go to the hospital, which is very important. The majority, they live in village, and the education is not that much. Okay. So we are trying the awareness program. I think it's very, very important.
Thank you very much. And I want to come to my sister from Malawi. You're working in the community. Now, there's something that Professor here has said, that the first step is awareness for women to go to the facility and deliver there. If I'm not wrong, and correct me if I'm wrong, Malawi has a skilled delivery rate or facility delivery rate of more than 90%. Is that true? But the maternal mortality in Malawi is still more than 400 per 100,000. 381, you see? So what is going on? So he said success has been go deliver in the facility. In Malawi, you have done a lot of awareness. You've actually made sure skilled delivery at facility level has increased to more than 90%. Actually, I think that Africa is was 94%. You still have almost 400 maternal mortality, and Bangladesh is under 200 at about 170. So what could be going wrong? And maybe, sorry? 136. So what could be happening in Malawi to affect this? And maybe in that you can also comment on whether, because the climate change in Malawi has been so impactful, whether there has actually been any direct correlation between the climate change effects and worsening maternal mortality and child mortality. Over to you.
Yeah, thank you so much. Indeed, what you are saying is very true about Malawi, that we really are at 97% for skilled birth attendants. But look at our mortality. In fact, we had reduced to 349 in 2020, but in 2022, the estimates went up to 381, and we are worried. Most likely, we are just thinking that maybe what is happening could be that we need to define this skilled birth attendant. Is it that indeed these women end up in the hands of a nurse or a doctor or somebody just working within the health facility? If that is the case, because some people can easily delegate to unskilled staff within health facilities. So we need to unpack that if that is a possibility, but we're just thinking. But we also know that most of our mothers are dying due to sepsis and of course, hemorrhage. But for sepsis, we think that we may be congested in our facilities now that all mothers have come to us. Now that even that tempts us to discharge them earlier than expected, because then we can't keep them all within the 48 hours that we actually, according to policy, we are supposed to keep them. Some are discharged early, and we must acknowledge that. And so therefore we have seen that they will come back with complication. So most likely, it means that yes, indeed, we have brought them into the facilities, but maybe the facilities, we need to make sure that they are big enough to accommodate them all. What we have done now is that we have invited them to come even before delivery, because we don't want them to start off late in the night and deliver on the way. So we have the maternity waiting homes right in the facilities. Mostly these are full wards. The waiting homes are very full. They will come and they wait there. But after they deliver, the postnatal ward is emptied within a short while. So therefore, we must start to look at how else do we make sure that the postnatal follow-up care is up to date. And now we are thinking of, the community midwifery assistants that we are now training. We have deployed them all to the health posts. Health posts are very close, are right in the community, so that some of the care must happen right in the community. We can do home visits right in the community. We can actually refer this woman with her neonate who had something that was questionable right from the facility to this midwifery assistant who will actually manage right in the community. You know that we have a crisis in terms of the workforce. We have had that problem for some time now, a chronic shortage of nurses and midwives, which we are working on. And I'm happy to report that this year alone, we have recruited about 3,000 nurses. But we want to make sure that those who are trained as community health nurse midwives are working right in the community. When we had this mass exodus in Malawi for nurses and midwives, we had to prioritize the care where we are going to give care. And that's how our community nurses ended up at the bedside. So you'll find that we have community nurses. They are not as many, they are very few, but the few that we have are not working in the community because we were responding to a crisis of nurses at a time when we had a mass exodus. We have now given a directive through my office that all of them must now move back, take their positions in the community. We hope with those types of interventions, we are going to make headway. Thank you.
Thank you very much. Yeah. So awareness has taken the mothers to the facility. 97%, I think, or 96, you said, well done. But there's a quality issue on the other side. That quality issue, the ability to keep the mothers, the postnatal care, might be reflected in the fiscal space and health, how much money is put in the health sector. Because getting to the facility is one thing. Maybe there's the cost to get to the facility is actually largely borne by the family. It's getting onto the bus and going there. But when you get there, are there adequate, as you said, health workforce that are well skilled? Is there capacity to make, to provide the health technologies and commodities that are needed, and to keep the mothers so they get quality care before they are released? Now, if you look at Malawi's, I could be wrong on this, Malawi's expenditure, public health expenditure per capita, it is under $20. If you just take the budget of the government every year and divide by the population. And that would be average in countries, my country is $42 per person. So it's not like, so Malawi is just a little lower, but on average, it will be about 40 across the sub-Saharan Africa. $40 per capita. Switzerland is using $4,000 per capita of public money. So this could be also the reflection. And the question is, what innovation do we need to leapfrog and actually reduce this inequality? Because fiscal space cannot be created overnight. And we know that governments, when you do the calculation of GDP and population in Africa, even if they allocated 15% Abuja, you'll not end up with more than $50. At best, even if you increase your tax efficiency to 25%, is now 15%, you will not end up with more than 50. So we know that the problem of financing is chronic. So for the question is, what innovation exists to resolve the challenges that Lucy and her team are facing. So let me come to Demby. Minister Demby of Sierra Leone. Recently, you launched the Child Action Plan. And I guess that the reason you did this is because, even as you look at maternal mortality, your child mortality is about 104 out of 1,000, or you could give me that the right statistics. So what have you seen as the progress on this Child Action Plan? And what are the things you want to share or change? And is there any message you want to also give on this resolution that has been brought by Somalia and what you've heard from your colleagues that our African and our countries across the world can learn from? Over to you, Dr. Demby.
Well, thank you very much. First, I must applaud Somalia for taking the lead in this resolution.
Yes,
before
thank
we
you.
endorse it.
Thank you.
I think for the case of Sierra Leone, you have to watch this space. We refuse to be defined by the numbers that are out there. When I arrived in Sierra Leone about 3 years ago, the maternal mortality had dropped from 1,300 per 100,000, one of the highest in the world, to about 717 per 100,000. And I just rallied the crowd around and said, look at Bangladesh, look at Ethiopia, look at Rwanda. We will turn this tide around. We will reduce maternal mortality from 717 to less than 300 in 3 years. And what that meant was a rallying call. A rallying call because we've been through Ebola. We've seen the response of the community, the nation, the world to Ebola. We've seen what a health security posture looks like. And we said, why don't we apply that to maternal mortality? The urgency, if you have one case of Ebola in your community, you deploy all of the resources around that case until you go through the incubation period, the 21 days, before you relax.
Mm-hmm.
Why don't we apply that same posture to pregnancy? Except that this time around, we have 9 months of engagement. We don't want pregnancy to be an event at labor and delivery. We want an engagement before, during, and after delivery. And so for Sierra Leone, what we've decided is for this to work well, the health system has to see every pregnancy in the country, all 300,000 of it. You have to be able to know that these pregnancies do exist. And every pregnant woman has to see the healthcare system in them. So one of the critical things that we've done is to commit that we're not going to glide into 2030. We're going to bend this curve deliberately. And so some key action that we've had was initially to declare a national emergency on maternal mortality. And we've done the same thing for infant mortality. Well, let me show you what the results have been. It's been going down dramatically. First, we realized that close to 20% of the maternal mortality occurs in teenagers. So you're not going to address this without focusing on teenagers and ensuring that you're able to have sexuality education in schools throughout the system, ensuring that you have commodities available, affordable, and accessible to them. We have a concept called radical inclusion, such that you cannot punish this girl twice for being pregnant. Usually it's intergenerational. So what we're saying is If you're pregnant, we'll work with you, we'll support you all the way to labor and delivery. If you're too young to deliver, we'll ensure that you have C-sections capability available to you. But as soon as you deliver, as soon as you're out of there, you're going back to school. You have to continue your education. So radical inclusion has just been phenomenal. It turns out these girls who go back to school are at the top of their classes. And what we've done also is to see that we have about 1,600 healthcare facilities in the country. In terms of access, we have 85% of the population have access to a health facility within a 5-kilometer radius. So we also have a high percentage of people who are delivering in facilities. Yet we have these fairly high mortality rates. So it's an issue of quality.
Yes.
How do you address quality in these facilities? And for us, we're looking at 4 key domains. First, looking at physical infrastructure, having a place that's clean enough, nice enough, that we encourage somebody to come and deliver there. Having water there, having electricity there, having equipment, having safety, having a clean space is vitally important. The second is having the full complement of staff in their numbers, in their skills to be able to provide services, and having empathy, having the patient at the top of their game. The third is ensuring that we have equipment and supplies in these facilities that are maintained, that are available and accessible. And the fourth is to ensure that you have the drugs as well. So we believe that as we address these things, we're addressing quality, and you begin to see the rapid change that's taking in these facilities. What we've also said is, as you work in these primary healthcare settings, you want to be sure that there are good referral systems from the primary healthcare to the secondary and tertiary facilities. And in the secondary and tertiary facilities, they should also be ready to receive more complex cases. But one of the coolest things that we've done now is we've created a local app that will allow the registration of every pregnancy with geolocation. And so what that will do for you is will ensure that this pregnant woman could see on a heat map all the facilities that are within the 5-kilometer radius of where they are and select the facility of their choice for their pregnancy. We link a community healthcare worker with that pregnancy, and that's their job, to ensure that they're good navigators, ensure that this person has access to all of the services. Normally, you have 4 encounters with the healthcare system. We've upped that to 8. At every encounter, there's a thorough workup to ensure if there are underlying comorbidities that are detected, to ensure that there's a rounded approach to this person, looking at nutrition, looking at health, looking at vaccination, looking at social circumstances, all of it, because we have a vested interest in influencing the outcome of that pregnancy. And you have a summary that will allow you to see the whole profile of the pregnancy. And I'll open my laptop here and see all the pregnancies in my country, where they are. But the cool thing is, if there's a normal pregnancy without any difficulties, they've been to the clinic, it comes as a green dot. For those with comorbidities, it's a yellow dot. If we lose any patient, it's a red dot. We could sit here and see, where do you see the yellow spots? And could you deploy resources and be able to influence and make sure that they become green? Or if they're yellow, you pay close attention to them until they have labor and delivery. If we see any red spot, we want to know why. We'll go in there and interrogate and see what led to the red spot and be able to intervene so that by the next month, we don't see this again. This is in real time. So the intent is to be able to have a digitized approach to this, be able to see all of these pregnant women and be able to influence the outcome of the pregnancy. The same applies to the children. There is no point in doing all of this for the pregnant woman and it delivers safely, and we all celebrate. And between age 0 and 6 months, you lose them. That is completely unacceptable. So we're deploying the whole new system out there to ensure that every child is visible to our healthcare system, and we have a rounded 360 approach to these children, ensuring their vaccination, ensuring their malaria, ensuring their nutrition, ensuring their cognitive ability, ensuring that they're ready for school. We've changed the approach to healthcare delivery in Sierra Leone. We're following the life course or the life stages approach.
Thank you.
So the pregnancy and the baby are the first 2 stages. For us, it's a combined stage, and we want to be able to support them.
Thank you. Thank you very much, Minister Demby. Wow. It's not easy at all, as you can see. I've just checked very quickly on the World Bank statistics on general domestic expenditure on health in each of these countries. I couldn't find very clear data on Somalia, and maybe Guled can tell us, but none of these countries, that is Bangladesh, Malawi, or Sierra Leone, are actually spending more than $15 per capita from public resources to do this work. So they're working with less than 15. The Minister of Health in Switzerland is working with 4,000. This is public money. So we must be more innovative. We cannot copy other countries. We have to learn from each other. And I would like to ask Joy Phumaphi. You are Minister of Health in Botswana. You're now leading the Africa Malaria Alliance. Could you give your reflections to what you've had here? And also because the Africa Union, of which you're part of the ecosystem, has been working on health financing, has been working on these maternal and child health issues. So maybe you can also add on that. So maybe 3 minutes of your time.
Thank you, Githinji, and
Thank you.
honorable ministers and distinguished participants. I just want to echo the honorable minister's congratulations to Somalia and the co-sponsors of the resolution. This is really something extremely important. I would like to address myself to the issues that were not raised by the ministers here. The first one is having a robust national health insurance scheme. We keep running away from that, but it is something that is absolutely critical, that can enable cross-subsidization between various income groups in the population. And I want to congratulate South Africa for working on that. And it's a very, very difficult process. They're having a major health reform process in South Africa, which will assist that. But I also wanted to talk about the other cross-cutting areas. You will find in a lot of our facilities on the continent, you have a hospital, but there's no access to electricity, no access to water, roads that are accessing that facility are seriously underdeveloped. So the national planning processes must be aligned in such a way that health is given a priority, so that roads that are leading to hospitals must be given priority. When you do the national development plan, electricity and water supplies in hospitals must be given priority. And there is even cross-cutting issues within the health sector itself. You will find that PMTCT coverage in a country is 80, 90%. But you'll find that the other issues that should be protecting the mother, for example, like IPT coverage, that is malaria in pregnancy, is in the 30s and 40s. Why is there no integration between these programs in order to ensure proper protection of the mother? I also want to talk about the legislative framework. We even in those countries on our continent, at least, where early marriage is outlawed, there is child marriage in many of our countries. It is continuing. Either it's a traditional practice or it's a religious practice. And we are not enforcing the law to protect these children. We must appreciate that most of our pregnancies are teenagers and youth. And these are the people we are losing, is the future of our country that we are losing, that we should be investing in. So any laws that can protect them must be enforced. Violence against women is a major factor that is in prohibiting their ability to engage effectively in this area. You'll find that for a woman to go to a health facility, she needs the permission of the husband. Without the permission of the husband, she's going to be beaten. So it's these legal frameworks that are going to protect the rights of the woman, empower the woman, give her access to economic empowerment activities that will enable her to pay for herself when she go to a health facility. Because the poor in our communities are women. They dominate poverty. Nutrition is very poor for the woman because in the family, she eats last. So if a young woman becomes pregnant, poorly nourished, the chance of her having a safe pregnancy and a safe delivery are very slim. So these cross-cutting issues are extremely important. Planning, legislative framework, and making sure that the responsibility of protecting the women from pregnancy and the youth as well. I have a serious gripe with UNAIDS when they came up with this 95, 95, 95. Our youth are continuing to be infected with HIV/AIDS. They did not have a target for closing the tap. You must close that tap. It is the young girls who are becoming the carriers of HIV/AIDS right now on our continent. So these cross-cutting issues, the cross-cutting issues must be addressed. And I really would like to thank the honorable ministers for their very, very rich contributions. Thank you, Githinji.
Thank you very, very, very much. Joy, I must also tell you what the per capita expenditure in Botswana is. I don't know how much it was when Joy was a minister, but it is actually close to 300. It's $270 per capita. So the Southern African region is actually by tax revenue much richer than Sub-Saharan Africa. So we must always share ideas and move forward, but they're still nowhere near where European countries are. And you raise the issue of legislation as a protection to us having to spend the money. So if we do legislation properly, we avoid future costs. And I think that's what you're talking about. Now, this issue of alignment that you've raised is a critical one. And at a moment like this, that we're actually asking all our partners in all the countries to be respectful of national agenda. So if a country wants to do prevention, it should have been told we are not in prevention anymore. You must accept that we moved on from there. Where is the value of local knowledge and local evidence? And this is where we are talking about the future of global health initiatives. And that is not only the global health initiatives of Gavi and Global Fund, but also UN system and our funders to ensure that there is room for local knowledge, so that if the country wants to shift more to prevention, it should be allowed, because that's the country plan and that's the country strategy. We are really short of time. I know this is a really good conversation, but I have to ask the ministers to step down. Please thank them for their contributions and Joy for joining. And it's been fantastic contribution. Thank you so, so much. And there'll be a time when we probably will ask a few questions and we'll call them up to answer. But because of time, we need to move on to the next session. But what a fantastic opening session there on the costs of not meeting the promise. Now, allow me to now invite partners who are working with these governments to now share their reflections on the failure of the promise and what it is that we can actually do with the partners. And to start, I'm going to ask Chris Elias to come up on stage. Dr. Chris Elias is the President Global Development at the Bill and Melinda Gates Foundation. So over to you, Chris. I'm told that you only have 3 minutes. Our boss is ordering me here. So you only have 3 minutes. Over to you, Chris. And then I'll ask Miriam Piri to come up. Miriam is the UNICEF Youth Delegate from Zambia. And yes, you could take that one. And then, of course, Revati Falke, Global Director, Health and Nutrition at Save the Children International. Good. So, Chris, let's start with you. You've listened to the ministers. What gaps do you see? And how do you think those gaps can be addressed with your partnerships? It's as simple as that. I won't ask you for the money now. We'll ask you later.
Yeah. You usually start with that, Githinji. So let me first start by thanking President Ramaphosa for his leadership on this issue, and Dr. Buthelez, please thank him on our behalf, as well as let me thank the government of Somalia and the other sponsors of the resolution for stepping forward in this World Health Assembly with, I think, what is a very important, one of the most important and timely resolutions that will be debated this week. I don't need to talk about the need. You did that very well in the first 2 minutes without words. That was very impressive. If I think about the curve, a flattening curve, and in some places a regressing curve, what that says to me is that we need innovations. And we have innovations. In fact, we have a number of innovations that are available today. The emotive package of interventions to prevent postpartum hemorrhage, facilitated by a simple plastic drape to help the skilled birth attendant estimate blood loss during delivery. New probiotic supplements, IV iron to treat severe maternal anemia, soon AI-driven ultrasound to help identify high-risk pregnancies. We have interventions and they're not coming in at scale. And we have a lot of new innovations in the pipeline, biomarkers for early detection of preeclampsia. We actually have a very robust innovation environment, but the challenge is that it often feels like we're pushing innovation into ill-prepared and sometimes reluctant health systems that are underfinanced. And so we need a paradigm shift. Rather than pushing new things into ill-prepared systems, we need systems that are robust and hungry for innovation. COVID-19 gave us a glimpse of what that looks like. Remember the first quarter of 2021, where heads of state were scrambling around trying to find where to buy ventilators, repurposing oxygen from the mining industry to serve hospitals, and demanding fair and equitable access to vaccines as they became available in emergency use authorization. With 800 women a day dying, we should have that same hunger for new innovation. So what would that look like? I think it begins at the country. In fact, it begins at the community level, as Dr. Demby, I think, explained with an incredible example from Sierra Leone. Countries need to be strengthening their primary healthcare systems, as well as figuring out how to create smooth and efficient transfer to more advanced secondary level care for comprehensive maternal care. And they need to demand from the global health institutions the kind of joined up financing that'll help create that universal health coverage vision with an emphasis on primary healthcare. We then need to look back at what some of the other delays are in getting new innovation into those systems. Researchers who take too long to publish new results and don't put it in open access journals. Normative agencies like the WHO that take too long to provide clear guidance to countries on the use of new interventions or new applications of existing innovations. I think if we change our mindset and we think about, we're not going to get there doing as many of you said, we're not going to get there doing what we've done to date. The curve shows us that. We're going to have to do something different. And we're going to have to pull new interventions and new innovation into systems so that every woman, child, and newborn has access to life-saving tools and that it's substantially well-financed and sustainably well-financed. So I think that's the mindset shift we need. I think the government of Somalia and the other co-sponsors have articulated a bit of that in somewhat UN speak, but if you read it carefully, it's saying we've got to change what we're doing and we've got to really motivate to do something different than we've done in the past. Thank you.
Thank you very much, Chris. Now, let me ask you for the money now. Well, you see, I talked about tax revenues in financing. So when I talk about $10 per capita, that was what the government provides out of its tax money. But then we know that that's not the only source of health financing in these countries. Another, probably, depending on country to country, 30 to 40% comes from development partners. So part of what the Gates Foundation does, USAID and others, is to top up the $10 that's in Sierra Leone or in Malawi and then top it up with another 15 or so. And then the mothers and their families top up the balance by selling their cows and sheep. So that comes to about $50 of what they're spending. So this innovation that we are talking about, if the government is the one to absorb it, it will have to absorb it out of these $10. So maybe I'll come back to you at the end to give you a minute to think about how do we actually work with the governments to ensure that we can actually layer money, what's called stacking of the government money, stack up the private philanthropy and the private sector to be able to afford this innovation. So let me first come to Phiri. You're working with UNICEF as a youth advocate. And we have talked a lot here, you heard from the ministers on adolescent health and the need to repurpose our policies, our practices to address adolescent health. How easy have you found it to do this with the government that you're working with? Over to you, Miriam.
Thank you so much, Dr. Gitahi, for that question. Distinguished delegates, good evening. It is an honor for me to share my experience on how I've worked with stakeholders and policymakers in issues of addressing youth-related issues and ensuring that the youth voice is heard. In my country, Zambia, where I come from, there's nothing for us without us. The Zambian government, as well as different stakeholders, have made sure that they take keen interest to make youths participate in issues that are affecting them. And we do have seats at those tables to come up with solutions to the many issues. And thanks to UNICEF Zambia for their continuously working with young people and ensuring advocacy, as well as issues of empowering us with different skills to spread awareness. I'm privileged to share I was part of the child parliamentarians in Zambia who are working hand in hand with governments to implement the Child Code Act. The Child Code Act was being debated upon in Parliament for over decades, but it was officially implemented in September 2022. So this law is simply a law that defines who a child is. It contains provisions of child rights violations and where you can report in case of these violations. It also contains punishments for perpetrators of these many violations. From that Code Act, we've seen the implementation of different policies that ensure young people as well as children participate, such as the Child Participation Framework and the Child Safeguarding Policy that is there to ensure that every child is protected from different vices, such as child abuse, child labor, as well as child marriage. I had an opportunity to work with young people from my community to see the adverse effects of climate change on children. And later on, I collected data and findings and presented it to the Minister of Green Economy. To show that the Zambian government actually listens to us, they are currently working on creating more climate resilient infrastructures for schools, looking at the changing climate, and as well as ensuring climate change education is compulsory to all learners from the first grade. Living as an adolescent girl in Zambia has not been easy because I have to witness experiences from my family and friends on how teenage pregnancy and lack of healthcare services affects young girls. So many young girls in my country, after falling pregnant, shun away from telling their family and friends because in fear of being disowned. And we have so many traditional practices clashing with modern technology. Most girls continuously living in isolation. And by the time it's too late to hide the pregnancy, when it's clearly visible, when you go for testing, you find the girl might have encountered health challenges due to lack of care and support. And by the time the pregnancy is discovered, it's too late to actually help the girl child. And as a result, the increase in maternal newborn deaths. My call to action for the government as well as different stakeholders to ensure they provide equitable healthcare services to all girls and implement different laws and initiatives such as Keep the Girl in School, and making sure that they use education as a cornerstone to make sure girls make more equitable decisions for themselves and have a bright future. I would like to thank the organizers for organizing this meeting. I would like to thank UNICEF Zambia for giving me an opportunity to share my experience living as an adolescent girl in Zambia. Thank you very much for your attention. As we say in Zambia, Ziko Mokwambili.
Okay. Thank you very much, Miriam. You'll teach me what you said in Zambian at the end so that I can actually sound as cool as you did. So I know you have a hard stop. So before I go to Save the Children, I want to come back to you to answer the question to Chris Elias, to answer the question I asked you on stacking and how to actually collaborate with government in view of their low fiscal space. How do partners come in to ensure that this innovation can be absorbed? What's your thoughts?
Oh, I have lots of thoughts, and I'm not sure any of them are sufficient in themselves. I mean, what we need is sustainable financing of the primary healthcare system. So we need actually more money for health. And so that goes to how governments think through their prioritization, how they understand the statistics, and how they allocate more of their scarce funding for the health sector. Within that, there's important broader discussions about debt relief and other pressures that are in this, this current economic crisis that also need to be addressed that I think we don't have time to get into. But even within the health sector, there's a need to get more health for the money, right? By prioritizing those things that are going to be most cost effective. Many countries prioritize tertiary care for elites in urban areas and underserve the rural areas where most of the statistics are substantially worse. So I think there's more that countries themselves can do in terms of the allocation and the effective allocation of health dollars. Now, in many low-income countries, that's not going to be sufficient. So we then also have to have the broader conversation about how overseas development assistance is sustained in a climate where there are many other demands given conflicts and humanitarian crises around the world. The ODA budgets are shrinking in many of the major donor countries. Again, we need to make a strong case for the value for money that these interventions in PMNCH deliver. And we need to then also address the fragmentation within the global health environment, where inputs to countries are often, from the support they get for health systems, from their concessional financing, from the multilateral development banks, from Gavi, from Global Fund, from many of the global health initiatives could be better joined up. And some countries that have made substantial progress have actually had strong leadership to insist that those global health partners align around a single plan, a single evaluation system, and align with the government and not just do their own thing in a fragmented way. And then there's a role for philanthropy. We're happy to be increasing our philanthropic budget at a time when most other development partners are reducing theirs. But philanthropy is not sufficient. The Gates Foundation is the largest philanthropy in the world, and it's a drop in the bucket compared to the resources that countries, the concessional funding from multilateral development banks and other major bilateral donors. So we'll do our part, looking at how we can potentially partner and be catalytic. We often play a role in taking the kinds of risks that governments can't and that the private sector won't. And we'll continue to do that, but we are doing more. And our CEO, Mark Sussman, in his annual letter, put out a call for other philanthropies to do more at this particularly difficult time in the economic crisis and with ODA stagnating or declining. So it's not one solution, but again, I think it begins at countries, and I think it begins with countries allocating their resources best and then articulating in a clear manner. And I think, again, Dr. Demby did this very well from Sierra Leone, what the challenges are and where they need development partners to come and align around their programs. Thank you.
Thank you very much, Chris. Yes, you can clap for Chris, and thank you. So I will excuse you now, and you may run out with our permission. But please keep that question of the money in mind. Thank you very much for joining us. Thank you, Chris. So thank you. As we come to an end of this phase, I'm going to ask Dr. Revati. Save the Children has actually been involved. Save the Children International has been involved in collecting views of civil society for the resolution by Somalia and supporting the hearing. And we would like to hear from you how that has been, whether you have the doors open, whether for civil society, or they were closed, like they open are sometimes. I can hear some laughter from WHO this side. And whether and what role you see for civil society in ensuring that once the resolution passes, that there is actually that it's actually the promise is actually met at country level. We don't want the promise here on the regional, we want it to be met at the country level. So Revati, over to you for your 3 or 4 minutes.
Yeah, thank you, Githinji, and I'll try to keep it as short as possible. First of all, of course, alongside all of us, I think we welcome the proposed resolution and commend Somalia's leadership alongside many of you in the room who have made this a reality, and hopefully it's passed on Wednesday. So we have heard several previous speakers identifying the number of countries that are falling behind in achieving these targets. And so for the overall development ambitions, we must not fail. And I think everybody in this room agrees with the acceleration of efforts that's needed. So coming to your question, Githinji, I would say that the example that you mentioned, the convening power of civil society organizations, this resolution is an excellent example amongst many others, where we have managed to get people around the table to discuss, to have a consensus on the joint ambition. And we've reached this place with that. About the doors being open, I would say, yes, they have been quite open. And of course, it's a long process. We've convened civil society organizations and other stakeholders over 5 months to be able to reach this consensus. We also partner with several of you in the room, including ministries, for the child survival action priorities that we have seen. And that means that we also work very closely in aligning not just the resources that are being pledged, delivered, but also the allocation of these resources at the country level in terms of child-sensitive programming and child-responsive deliverables that we identify. At the national level, I would say that CSOs play quite an important role in meaningful inclusion of the vulnerable groups. And this also means that the voices of organizations like us and those vulnerable are elevated to global forums, but also being heard at the subnational and national level policy making. But of course, as you mentioned, Githinji, consensus on policy and the resolution is just the first step. I think we do need to make sure that the resources follow the ambitions that we are setting for this. And more importantly, we also strengthen the human resources that will need to deliver this at scale. Of course, NGOs like ours, together with local organizations, do play an important role in operationalizing ambitions, global ambitions like the ones that we're setting for the resolution, but also making sure that the programs that are implemented are mindful of the inequities and the inequalities that exist today. So I'm very pleased to say that we were part of almost 17 policy wins in the last year, and we reached almost 17.9 million children and mothers and adults through our programming. So yes, scale is one of the other components that we bring to this conversation. My intervention will not be complete if I don't mention CSOs and NGOs' contributions to the development and capacitating of community health workers. I think they are very key in making sure that the services are reaching the hardest to reach areas, which is where majority of the vulnerable populations live. And likewise, operating in all contexts. I think we've heard again and again that majority of the maternal and child health mortality is occurring in countries that are fragile or conflict. So operating in these organizations. And I'll end with saying the contributions that we make to the overall evidence generation, synthesis, and sharing. I think feeding that information back from even the innovations that CSOs and NGOs like us pilot and proving or demonstrating, I would say proving is a strong word, demonstrating how these innovations can be scaled. So I think, and of course, along with that comes the responsibility for accountability. So civil society organizations do play a critical role through monitoring of the progress of these resolutions or other policies that are being implemented and making sure all of us remain on track. Thank you.
Thank you. Thank you very, very much. And For the CSOs in the room, because I see many, it is not the WHO that will implement the resolution. It is the government. So we need to go back, read the resolution, and ensure we use the legislative frameworks, the parliament, to ensure that the resolution is implemented at country level. So a big hand to our guests here. Thank you very much, Miriam and Rebati. So please, yeah. Thank you very, very much. We are now coming to the last session of this. And the question is, we've heard from the countries, we've heard from the partnerships. Now we want to hear about the enabling environment. So what is it that the UN system, WHO and others are, in addition to these resolutions, going to do? Because they also provide a lot of technical support to countries and in some cases, financing. So I would like to invite Bruce. Bruce as well. Oh yeah, I had seen you standing there in the corner.
I was instructed to be here.
I see. You move very stealthily because I didn't see, I was watching you at that corner. So for the next three, I'm going to ask them to speak from this podium so they can speak quickly. If I give them a seat, they'll keep us waiting. So Bruce, 2 minutes to just share what you've heard from here and what the role of 3 minutes? Okay, 2.5, fine, let's do this.
Thank you so much, Githinji. Excellencies, ladies and gentlemen, it's such an honor to have a chance to join this panel, the rest of my panel is down here, and speak to this, this agenda. So appropriate that we're doing it this evening before we kick off the World Health Assembly tomorrow morning, because we're shining a big, bright spotlight right on the issue that should be at the center of everybody's agenda over the coming week. Githinji, by the way, I always listen to him very carefully because he always says things. He repeats the things that are really important many, many times. And while I was standing in the back there, I kept hearing, okay, we're at time. Okay, we're at time. But I am going to take a minute to say a couple of things that I do think are important. First, on the context for our discussions today for the Assembly. We are in a situation that should be absolutely shameful. When we look at where we are with respect to maternal mortality, 800 women dying every single day in childbirth pregnancy. Someone's already used the numbers. 5 million children still dying under 5 every year, as you know, should be absolutely shameful. That is concerning. We're off track. But if we look going forward, we're in a world of climate change, of conflict. We're in a world of escalating costs of living as well, and the poly crisis. So it's going to be more difficult. We're off track. It's going to get even harder. And then third, of course, those poly crises are going to hit these populations that this partnership stands for worse. So we have a lot to do. The next week will be important. We have a really important resolution, and I want to really thank the government of Somalia. They, stood up and said, we need a resolution on this, one of the toughest issues, and member states have come behind it. Congratulations to Somalia, but a very important resolution, and thank you for that. The clapping doesn't come out of my time, right? Okay, but thank you. The second thing we're going to do is we're going to launch a new global, new strategy for global health. And that strategy is anchored in 6 big strategic objectives. Many of you have played a role in helping shape those strategic objectives. Common to every single one of them is advancing the agenda on maternal, child, newborn, adolescent health across every single one of them as you read it, and really anchors all of them. But those are only resolutions. They're not going to move things very far in and of themselves. So I think the question I asked, what do we need most? So 5 things. The political leadership, which is what this event is all about. Galvanizing, keeping it. The second thing we need, Chris spoke to it, prioritizing what works. And I want to thank Minister Demby for your event. Look, I've got your 6 actions about what we need to do to advance this agenda, proven things to prioritize and advance in every single country. Someone spoke earlier, a primary healthcare approach. Make that system work. That approach can bring maternal mortality way down, newborn mortality way down as well. It's simple, it's cost effective, it's inclusive, it's what we need to be doing. But we need partnership, and why this event is so important, and why I left, by the way, the launch of the WHO investment round, which is supposed to be the most important thing we do, get my organization funded, but more important is partnerships, because what we aspire to cannot be achieved without the power of partnership. And I want to thank Miriam for the point that she made in the last panel, because she talked at the end about people. Nothing for us without us. We have got to actually have the people who are affected at the center of this agenda and driving it. We, WHO, completely committed to this agenda. It cross-cuts our entire vision, maternal mortality in particular. That's how we're going to measure ourselves for the next 4 years. So we're committed. And with the UN, with our sister agencies, I love calling TED my sister, we are united and we will help as we go forward. So thank you all for being here. Githinji, thanks for the extra 2 minutes. And thank you for everything we'll do this week to get all this through and in the years going forward to bring maternal mortality, child mortality way down and make the world way better for adolescents. Thank you.
Thank you, please. Thank you very much, Bruce. You've done better than I'd expected in terms of time management, you know, but so congratulations there. I'll be calling you a sister to speak shortly. Yeah, it's a sister organizations, you know, you heard that, Ted. Eh? Now, I would like to, we had two co-hosts for this event, of course. We had UNFPA and UNICEF. So now I'd like to invite Pernille Fenger to come and speak, Director of the UNFPA Geneva office. So please come over. 3 minutes. You negotiated for you.
Yeah, I got the message, and what great energy. I think we all offer a good start with all the, as I said, all the energy that Bruce has come up with. I would follow many others and also thank Somalia. We are very grateful for the leading work that you have undertaken, of course, with the other co-sponsors. Extremely important resolutions that we look forward to witnessing being adopted next week. And then I'd also make sure that I thank South Africa and President Ramaphosa for establishing the Global Leaders Network. This is extremely important that we have leadership at the highest level to set the direction and make sure that we have impact. And what we've heard today from many of the very interesting speakers is really a cause of concern. We, as we've heard, this is we need to do better. And what I personally find striking, and coming also from UNFPA, is that the poor quality of care in low and middle income countries, they actually accounts for 50% of maternal mortality and 60% of neonatal death. We simply must do better. The quality of care really needs to improve. Chris Elias was speaking about shifts, and in UNFPA we also very focused on shifts that are needed in order to make progress. And the first shift that we need to see is really investment in sex and reproductive health. And when we say sex and reproductive health, we mean the whole area of sex and reproductive health. We're looking at preventing unattended pregnancy, access to contraception, addressing unsafe abortion, and also expanding access to antenatal and interpartum care and access to emergency care within 2 hours of travel, as well as postpartum care. The full range needs investment. Secondly, we also look at a transition to an implementation of midwifery models of care. I spoke before of the lack of proper care. And UNFPA has been supporting governments for the past 15 years, and we know it works. There was a good example of from Bangladesh earlier on, and I also want to salute Bangladesh for the amazing work that they've been doing. And I understand that the Prime Minister of Bangladesh has now announced 10,000 more midwives to be educated in. I think that calls for a round of applause. That is the way to go. We need properly trained midwives to accommodate women, not just when they deliver, but all through their pregnancy and afterwards. And lastly, but certainly not least, we need to listen to women and we need to trust women. There are too many women when they are in a pregnancy or when they deliver that experience trauma and injury because of poor quality of care. And far too many women, they're experiencing maltreatment during pregnancy and delivery. I mean, the moment when they should be being cared for, they are being maltreated. And then too many adolescents, they are not met with compassion, but they are met with judgment. And we have to simply do better on that. So we need to invest in respectful maternity care and institutionalized mechanisms to improve service of quality. As Bruce was saying, we as UNFPA are definitely standing behind this agenda. We work in partnership with our sister brother agencies, but of course also with civil society, and to ensure that that there is and in partnership with the countries where we're working. So together we can do better, and I think we are off to a good start, and let's keep it up. Thank you very much.
Thank you very much. And the last speaker in this segment again is event co-host UNICEF. This is Ted Chaiban, UNICEF Deputy Executive Director. And I think I did not tell you, for those of you who don't know Bruce, Bruce is the is the Assistant Director General for UHC and Life Course at WHO. So Ted, it's your 3 minutes now. Over to you.
Thank you, Githinji, Excellencies. Thank you, Miriam, for your great comments, and thanks to Somalia and to all the sponsors of the resolution. I was sitting there during the 2 minutes where Githinji asked us to be silent, and I was thinking of that one woman who died during those 2 minutes, the 20 children below the age of 5 who died, and the 2 adolescents who died, most from preventable deaths. And since then, we've been here about 120 minutes. So how many more have died that we can all work together to avoid? And I'm going to focus on 3 points. They've been made, but I'm going to focus on them for emphasis. Firstly is the importance of focusing on areas and investments where needs are greatest. And for UNICEF, that means focusing on the regions and the countries where the burdens of child and maternal mortality are highest. I think the only person who mentioned today a key feature that we need to make sure we don't forget is our colleague from Save the Children, which is that, as if often the case in child health and survival, the vulnerabilities are highest in fragile and humanitarian settings. About half of global under 5 deaths in 2022 occurred in such settings. So as we leave this room, this has to be a key area of our focus. So that's the first point. The second point is we need to align. Everyone has spoken about the resources. You spoke about the fiscal space. And yet we still have an architecture that's fragmented, that's focused on individual diseases. And so we need to leave here and commit to align behind countries, behind ministers that show us the way, like Minister Demby, like Minister Lalsen, to be behind one plan, one budget, and have one group of partners that support these plans and these budgets. And then thirdly, we need to be efficient in the way we utilize our resources. And within such plans and such budget, within the partnerships that back these plans and budget, focus on primary healthcare as a platform that is the most important, where there's a $40 return for every dollar spent, and where community health workers give a 10-fold return on investment. So that's why UNICEF is championing the community health delivery partnership and calling on all of us to strengthen, pay, and protect community health workers, 70% of whom are women, and to invest in community-based primary healthcare. It's really the best way to deal with the equity and gap issues that we saw so clearly and starkly illustrated during COVID. We have, as many of the speakers have said, the solutions on hand. We don't need to reinvent the wheel. It's really about rediscovering that passion and that commitment to act collectively and responsibly for women and children everywhere. So let's get to work. We know what to do. We have shown that success at scale is possible. by reducing the prevalence of stunting by 45% and having under 5 mortality since 1990. Let's do it again. Let's half mortality again by 50% and live up to the promise of the resolution introduced by Somalia and the other sponsors. Please count on UNICEF on the road ahead. Thank you very much.
Thank you very much to our partners. And Ted, I've just done a quick arithmetic calculation. Within the 120 minutes, 60 women have died, 120 adolescents, and 1,200 under fives within the time we've been here as the cost of our inaction. We're now coming to an end of this. I want you to think about that and remember the 2 minutes of silence. And every time you remember those, then you have to ask yourself, what are we doing to save those lives within those 2 minutes? My own personal story is invest in women. My mother is the best public health officer I've ever met. She's 89, 9 children, I'm number 8, all alive, and she started to her first child in 1952. Delivered all of them, took care of them, because you know what? The person with the biggest interest in the survival of the child is the mother, the one who carried it for 9 months. So please keep that in mind. Women are the best public health officers. Let us invest in them. I now want to close this event by inviting my employer, Rajat Khosla. So Rajat is the new executive director of PMNCH. Just joined recently, and I noticed that the person who was the executive director of PMNCH before, when we joined and we started working together, is Helga. Helga, thank you very much for the work you did at PMNCH. Thank you. Rajat, over to you. Rajat will close the session and invite you to the reception. Over to you, Rajat. Thank you very much, all. Thank you.
Thank you, Githinji, so much. And for me, it's a very formidable task to come to a conclusion of such a rich conversation. But before I do any of those rather, inappropriate attempts to make a summary, can I please have a huge round for Githinji? He's such a rock star. I don't know how you do it. That was amazing. And his shoes as well. Absolutely. And my sincere thanks to a plethora of people that I should be thanking, starting with the South African presidency. Thank you so much for your leadership of the Global Leaders Network. To Somalia for making us having this conversation today and your leadership on the issue. To our co-sponsors, UNICEF, UNFPA, WHO, for showing your leadership. But colleagues, as I said, I will not try and attempt to summarize this conversation that we had. I just want to raise 3 points for our reflection as we go from this conversation and for the rest of the week through the World Health Assembly. The first is, why are we having this conversation in 2024? Bruce said it very rightly when he took the stand. They're saying it's rather shameful that we are having this conversation, that many people are dying of preventable causes in childbirth, under 5, and in adolescence. This must be an affront to our collective conscience. I don't know how we get over this fact. But the fact is that we were making immense gains. We were doing very well. We were on the path of absolute recovery from a lot of these issues. Why did we lose the momentum? Why is it that these are not issues that are getting the kind of financing that we expect them to? What happened as competing agendas took over, and why even within the multilateral system, it's not seen as a priority today as it was a few years ago? So my second point is, words are good. We need action, and we demand action from each other. Somebody asked me at another panel earlier today, what's the big superpower each one of us had on the panel? And it came to me, I said, our biggest is our partners. The 1,450 that we are because of you. If you are not there, we don't exist. So what can we do to ensure action that we don't have this conversation in another 10 years? That we do have the investments and that we do have the scale that all of us talked about. And these are issues that are seen as a priority. because unfortunately, they aren't right now. My final point is accountability. How do we ensure we hold each other to account? This is why change will happen. Change will not happen only through the higher echelons of the institutions in the city. Change will happen when we start demanding accountability and change from our respective governments, from each other, and from the system writ at large. I don't want to stand between you and the reception. It's been a great first week, and thank you so much for joining the Partnership for Maternal, Newborn, and Child Health for this event. Thank you.